Okay. Welcome everyone to another exciting edition of GynoScope, a unique academic collaboration between Dr. Aditya Nimbkar and SIMSOG. GynoScope is an evolving platform designed with a clear mission to foster a dynamic space where emerging medical professionals can unite, engage, and deepen their expertise in the field of obstetrics and gynecology. Our vision is to offer an enriching experience that goes beyond conventional learning with a mix of thought provoking case studies, interactive discussions, and challenging quizzes like Dr. Nimka's Brain Benders, which have become a beloved source for many. Our case today is fetal growth restriction presented by Apoorva Malwade and Uditi Joshi from LTMMC and General Hospital, Mumbai. We're incredibly grateful to have all of you with us today for another session filled with invaluable insights, collaborative learning, and clinical exploration. So let's dive in. Over to you, Dr. Aditya.
Yeah, hi everyone. Thank you so much for the introduction. So, welcome everyone. And we still have four more slots so people can join in. So, today's session is going to be on fetal growth restriction. We are going to be covering everything on it. So, Apurva and Uditi, are you ready?
Yes, sir.
Okay, let's begin.
Hi, everyone. We're Apoorva. I'm Uditi Joshi, and I'm with my colleague Apoorva Malwade. We're going to be presenting a case on fetal growth restriction. Mrs. A.R., a 21-year-old primary gravida, resident of Vikhroli, hailing from Malkapur, has studied till 12th grade, is a homemaker by occupation belonging to the lower socioeconomic class, is married since 1 year in a non-consanguineous marriage. Her last menstrual period was on 18th of November 2024, and her expected date of delivery is 25th August 2025 by Neely's formula. On 22nd of July, her period of gestation was 35 weeks and 2 days. Patient has been referred to Sion in view of suspected fetal growth restriction during regular ANC follow-up and admitted for monitoring and optimization of pregnancy. There is no history of pain in abdomen, no history of bleeding or leaking per vaginum, no history of decreased fetal movements. The exact LMP was known with a regular 28-day cycle, no use of OC pills, and conception was spontaneous, and dating scan was done in first trimester. Patient and husband have normal build. Are we audible?
Yeah, you're audible.
It was a
You.
spontaneous conception confirmed at 1.5 months of amenorrhea by UPT at home. Patient went to a local clinic for checkup at Malkapur, where a dating scan was done, which was said to be normal. She then experienced pain in abdomen, for which she visited local clinic and was told that it was normal. She had history of excessive vomiting throughout the day, not controlled by medications, requiring IV saline or glucose, with inability to eat or drink for 4 to 5 days at a time. This continued on and off till the 7th month of gestation, but patient was unable to receive treatment after the first episode due to financial constraints and under-equipped local PHC. NTNB scan was done at 12 weeks, which was said to be normal. There is no history of fever with rashes, bleeding per vaginum, exposure to radiation, or any drug intake. The weight gain was 4 kilograms till the 6th month from pre-pregnancy weight of 42 kgs. Routine ANC checkup was done at the start of the 4th month, and BP, blood pressure, sugar, and hemoglobin were in the normal range. Iron, folic acid, and calcium supplementation was started, and 2 doses of TT were taken. Quickening was felt at the 5th month. Anomaly scan was also done in the 5th month, which was said to be normal. She had fever in the 6th month for 1 day, for which she visited a local clinic and was started on paracetamol, which relieved the fever. She had an episode of leaking per vaginum a few days after, for which she was given a pessary and antibiotics. There was no history of headache, blurring of vision, epigastric pain, decreased urine output, or swelling of feet. The patient went for normal ANC follow-up at Rajawadi after moving to her mother's house, where fetal growth restriction was suspected and USG was done to confirm. She was referred to Sion Hospital, where serial USGs were done, 2 of which showed the same fetal weight, following which she was admitted. She was started on nutritional supplements and advised to maintain a daily fetal kick count chart. Weight gain was 4 kilograms from the 6th month weight, which was 46 kilograms. No history of headache, blurring of vision, epigastric pain, decreased urine output, and swelling of feet. No history of bleeding or leaking per vaginum or pain in abdomen. No history of burning micturition. She had her menarche at 13 years of age. She had 28-day regular cycles and she bled for 6 days in the cycle. She soaked 3 pads per day without any passage of clots or dysmenorrhea. Her last menstrual period was on 18th of November 2024. She has no history of OC pill usage, irregular cycles, or any abortions. She was a primi gravida. There is no history of diabetes, hypertension, chronic kidney disease, TB contact, epilepsy, thyroid, or any bleeding disorders, or any long-standing illnesses. No history of Apla syndrome or any autoimmune disorders, no history of COPD, bronchitis, or asthma, no past medical or surgical cause for admission to hospital. On inquiry, patient had a history of significant long-standing psychosocial stressors, including substance abuse from husband and verbal abuse from mother-in-law, with a history of disordered eating before marriage, possibly anorexia nervosa, and currently exhibits symptoms suggestive of PTSD. Her sleep was decreased. She slept for an hour or two every night and 1 or 2 hours in the day, which led to fatigue. She had hard stools and her bladder habits were normal. She denies smoking or any addictions and her blood group is A positive. Patient eats vegetarian food during pregnancy. In the second to fourth month of pregnancy, the patient had a daily calorie intake of 410 kilocalories and protein intake of 10.3 grams, which is a deficit of approximately 1000 kilocalories and 32 grams of protein. You can see the meal chart here. In the next trimester, the patient had a calorie intake of 940 kilocalories and protein intake of 36.4 grams, which is a 860 kilocalorie and 34.6 gram protein deficit. Her mother had 6 children who were delivered full-term normal vaginal delivery. There is no history of any pregnancy complications in any of her siblings. Her husband consumes chewing tobacco. There is no history of diabetes, hypertension, autoimmune conditions, epilepsy, or any bleeding or thyroid disorders in her family. There is no history of any congenital disorders.
The patient is thinly built, poorly nourished, and has a height of 5 feet and 3 inches with a pre-pregnancy weight of 42 kilograms. This makes her pre-pregnancy BMI of 16.4. Her current weight in the third trimester is 50 kilograms. She does not have any abnormal gait or spinal deformities. On examination, she is afebrile. Her pulse was 82 beats per minute, which was regular and had a normal volume with no special character or no radial or radiofemoral delay felt. All peripheral pulses were well felt. Her respiratory rate is 20 per minute, abdominothoracic type of breathing. Her blood pressure is 110 by 80 millimeters of mercury in the right upper limb in the sitting position. She does not have any pallor, icterus, cyanosis, clubbing, lymphadenopathy, or edema. On systemic examination, the first and second heart sound are heard without any murmurs. The air entry is bilaterally equal with normal vesicular breath sounds. She is conscious, cooperative, and well-oriented with no focal neurological deficits. And the thyroid is normal with no swelling. The breast was also normal. There was no nipple retraction, discharge, or fissures, and there was no palpable marks. On an abdominal examination, in a well-lit private room with due informed consent, her abdomen was uniformly craniocaudally distended. The umbilicus was flat. The linea nigra was seen. There were no scars or discharging sinuses, and the cough impulse was absent in the hernial orifices. The fundal height on palpation was 30 weeks. The symphysiofundal height was 32 centimeters on measurement, and her abdominal girth was 84 centimeters on measurement. On performing the first Leopold's maneuver, a broad, soft, irregular, non-ballotable mass was palpated at the fundus, suggestive of the buttocks. On performing the second Leopold's maneuver, on the left side, a hard, curved, board-like structures were felt, suggestive of the fetal back, and on the right, small, knobby, irregular parts were felt, suggestive of the limbs. On the third Leopold's maneuver, a smooth, hard, globular, and freely ballotable structure was felt, suggestive of the fetal head. And on the fourth Leopold's, the fingers did not converge, suggesting the head was not engaged. On auscultation, the fetal heart sound was heard in the left spino-umbilical line, and the fetal heart rate was 130 beats per minute and regular. So to summarize our case, Mrs. A.R., a 21-year-old primi gravida with 35 weeks and 2 days of gestation, came for a routine ANC checkup with no specific complaints, perceiving normal fetal movements. She has had episodes of vomiting, pain in abdomen, and leaking pervaginally. She does not have any history of bleeding pervaginally. On examination, there was no pallor. The blood pressure was 110 by 80 mm of mercury. The fundal height was 30 weeks, and the symphysiofundal height was 32 centimeters. A single live fetus present in cephalic presentation with a fetal heart rate of 130 beats per minute, regular and heard on the left spinoumbilical line. Our provisional diagnosis is a 21-year-old primary gravida with 35 weeks and 2 days of gestation with suspected fetal growth restriction, possibly due to low BMI, poor maternal nutrition, hyperemesis, anorexia, other stressors during pregnancy with single live fetus, cephalic presentation, and not in labor.
Great case, very precise. Could you just go on to your first slide?
Yes, sir.
Yeah. So, in your demographic details, could you tell me which all points are significant in terms of your case of fetal growth restriction?
Sir, um, her age is 21 years and she's a nulli gravida, like she's a primary gravida, and she has not had any pregnancies in the past, which is a risk factor for fetal growth restriction. She is
Why?
hailing
Could you tell
from
me?
Sir, at such a young age, the body is not physiologically ready for a pregnancy, and the women are tend to be malnutrition at a younger age. So that is why it can be a risk factor.
Irrespective of what we believe, the ideal age for pregnancy is said to be around 20 to 24 years of age. So, age I wouldn't really call 21 years as something young. But you did mention about primary gravida being a risk factor. I would rather
Sir, and the other risk factors are there.
no. Could you
So
tell me primary gravida is the right answer? I'm telling you it's the right answer. Could you just tell me though why is it why is it a risk factor though?
because there is, I mean, there can be a placental cause because of her being a primary gravida, because she's not exposed to the paternal antigens, and I mean, she's
Excellent.
exposed to the paternal
Great answer.
antigens for the first time.
Correct. So because it is being what do I say? Because it is being exposed, the mother is being exposed to those antigens of the father for the first time. The body might have a slight bit of foreign body reaction, kind of a reaction, basically. So in that scenario, you would find that there is going to be a bit of rejection. And when I say rejection, there is going to be impaired trophoblastic invasion. Now, we have all read about trophoblastic invasion in the chapter of preeclampsia. And if there is any issue with the trophoblastic invasion of your spiral arterioles, then that is going to lead to placental cause of fetal growth restriction. So yes, primary gravida. Similarly, if the female is going to have her next pregnancy after 10 years of first pregnancy, or if she has another partner with whom she has her next pregnancy, even in this case, the previous pregnancy is going to be rendered futile, it is going to be obsolete, and she will again be at a risk of having fetal growth restriction. So yes, correct. Fine. Anything else in your history?
Sir, she belongs to the lower socioeconomic class, which which predisposes her to malnutrition, and also she might be living in close quarters with other people, which can predispose her to having TB infections or any other infections.
Okay, I would give that to you. That's a good answer.
Sir,
Could you just detail in a little more as to how will infections lead to or something like TB will lead to preeclampsia? That's a correct answer, I would say, but how would you connect them?
Sir, if a patient has any chronic infections, it would be a stress-like state for the body, and
Very good.
she would be able to she won't be able to give adequate nutrition to the fetus at the time, and there would also
Good.
be increased cortisol in the body.
Very good. That's a good answer. So basically, increased stress and also infections like tuberculosis are examples of chronic inflammation. So the body is having lots of cytokines, and a state of chronic inflammation is going to ensure that there is global endothelial dysfunction in the body. And whenever there is endothelial dysfunction, you do know that there is going to be issue in the placental growth, placental formation as well. The spiral arterioles are not going to function normally. So yes, that is a risk factor towards fetal growth restriction. And yes, malnutrition, as you suggested, micronutrients that are very essential for the growth of the fetus are going to be depleted in this female. So that is another reason why the baby might be malnourished and might have fetal growth restriction. Okay. Uh,
Sir, she
Something
is
on the right. Yeah, yeah, tell me.
So she's also from Malkapur, which is a remote village where there is inadequate healthcare facilities present, which could also which could lead
Very
to
good.
abnormal ANC care.
Abnormal ANC care. Could you tell me a little more on what do you exactly mean by abnormal ANC care? What exactly might be missed?
Sir,
Repeat the USG scans at the normal times and then she may be lost to follow up if
Excellent,
the system for
excellent.
the scans is
Very,
not present in her local PHC.
sir,
very
also
good.
complex investigations like Doppler might not be available
Might
to
not
her.
be done. Yes.
And
So this is going to
any
be for picking up FGR. Is there anything that poor ANC care related to ultrasound, inadequate ultrasound, can also be implicated in what do I say, prevention of fetal growth restriction? Any ultrasound that can prevent, that can possibly prevent FGR?
sir, the uh, uterine artery
Excellent,
Doppler
very
is
good.
done at
When is it done? The earliest that it can be done at?
sir 11th to 14th week.
Very good. 11 to 14 weeks. That is the right time because even your trophoblastic invasion is going on at that time. So if you begin her on which drug, can you delay or can you probably even prevent fetal growth restriction? Which drug?
Sir, aspirin.
Yeah, very good. Okay, you were saying some point.
Sir, and it will also affect her treatment if the local PHC is not well equipped to treat the fetal growth restriction after it is detected.
Very good. So if it is not well equipped, it is going to be a problem. Also, if that PHC is not getting an adequate supply of medicines, there are a few medicines apart from aspirin as well, which are implicated, which are said to have a positive effect on fetal growth restriction and preventing it, which includes vitamin D and folic acid. So even that can be an issue. That can be an issue for that PHC. Now that you have anyway mentioned about PHC, one favorite question that I rather would discuss in anemia, but I would just want to ask you, do you believe ferrous sulfate or any iron supplement can lead to iron fetal growth restriction?
Sir, they could like ferrous is known to cause GIT problems. So it
Okay.
could potentially cause malabsorption also. I'm not
Yeah,
sure, sir.
but that's a good answer. That's a very good answer. But assume that she is well suited to ferrous sulfate and she does not have any gastric symptoms. In that scenario, do you think maternal anemia, if uncorrected, can lead to fetal anemia?
No, sir, maternal anemia won't lead to fetal anemia because there is ferroportin like channels present which would shunt all of the iron from the mother to the fetus. So the
Excellent
fetus,
answer. That's an amazing answer. Where did you read this?
sir, from Datta.
Excellent answer. That's a lovely answer. So ferroportin, which is, I would say, a transporter which transports ferro, which is your iron. The work of ferroportin is to pull iron from one cell and to push it into the other. So you have ferroportin that is present in your gut mucosa cells, basically your duodenal mucosal cells, and also in your syncytial trophoblasts. Now, in pregnancy, the levels of hepcidin go down. I'm going to be discussing this in anemia. So, the levels of hepcidin go down. So, the moment hepcidin goes down, ferroportin starts overfunctioning. Hence, the absorption of iron in the mother is increased and also in the fetus it is increased. So, the fetus is going to extract all possible iron from the mother for itself, like a parasite, and is going to ensure that it is never going to face fetal anemia because of iron deficiency. So yes, your answer about ferrous sulfate and gastritis leading to fetal, it won't lead to probably fetal growth restriction, but probably a little lesser on birth weight. Definitely. That's a good answer. Okay. On your demographic details slide, on the right side, you have mentioned about LMP, EDD, POG. Does it have any bearing on your case?
Sir, it would help us differentiate from like early and late fetal growth restriction.
And sir, if the LMP is not accurate, the differential diagnosis for FGR would be wrong dates.
Yeah, very good. That is one of the first differentials, wrong dates. Excellent answer. So wrong dates, incorrect dates, very common in our country, can lead to, especially in, where would you suspect wrong dates to be more common? In a rural setup or in a urban setup?
Sir, in a rural setup.
Hmm. What if I tell you it is urban setup? Could you
Sir,
tell me
because of
why?
OC pill consumption, probably.
Okay, OC pill. What more than OC pill? Something much more common.
So maybe recent abortions, or if the mother is lactating and
No, PCOS, very
PCOS.
common in urban
PCOS.
areas. Sedentary lifestyle. Sedentary lifestyle, these women have very poor cycles, especially in urban areas with worse lifestyles, I would say. They tend to have erratic cycles and they tend to just know about their pregnancy almost in the fourth or fifth month when they start feeling that their abdomen is getting heavier. They would say that I would anyway not bleed for 3 to 4 months at a stretch, but this time I started realizing that I am also having significant weight gains. That is how it is diagnosed. So yes, in urban areas, I would agree with your point. Rural areas maybe yes, but then from what my observation has been, these rural people are in fact a lot more particular and they do remember the dates. They do remember the dates in terms of festivals and all as well. कि इस महीने के ये इसमें हुआ था because festivals and menstruation is a very significant cultural aspect in the rural areas. So they do remember in terms of that. But in our setup, in urban setup, definitely PCOS has a bearing on it. Fine. So your patient is of 35 weeks right now. So she's in the late third trimester. Okay. Um, Next slide. So she had been referred to Sion. Oh, that's a very cute way of saying Sion Hospital. Sion in view of suspected fetal growth restriction. Okay. You have mentioned fetal growth restriction over here. Is there any difference between IUGR and FGR?
sir, FGR is the new term for IUGR, like
Yes.
it
Why? Why was
replaced
it
it. Because
renamed?
Sir, intrauterine growth retardation, I mean, the retardation aspect of it had a very negative mental
Yeah,
health
it had an again
connotation.
negative connotation that the baby is probably mentally retarded. That is what it was implying, which was not the case. So, fetal growth restriction. So, now we are coming to a very pertinent point. What is the definition of fetal growth restriction?
Sir, fetal growth restriction is when the fetus fails to reach its growth potential because of maternal, fetal, or placental factors, pathological factors,
Okay.
and the estimated fetal weight is below the 10th percentile.
Okay, I would want to give you one more chance of correcting. Is it less than 10th percentile? We are talking about fetal growth restriction. One more chance
Sir,
to correct your answer.
yes, sir. Less than third percentile is the single definitive criteria,
Yes,
and if
very
it is
good.
less than 10th percentile, there should also be abnormal uterine artery Doppler.
Uterine or umbilical artery Doppler, it depends on at what gestation you are diagnosing.
Yes, sir.
Okay, then tell me what is the difference between small for gestational age and fetal growth restriction? Let
so
me just give you
small.
an example for the sake of others as well. You have a 35 weeks fetus, let us assume. Let us assume your pregnancy is of 37 weeks and there are two babies. One is having fetal growth restriction, the other one is having small for gestational age. The small for gestational age वाली mother is also very short statured, वजन भी कम है उसका, whereas this mother is well built, well nourished mother who is having who is having preeclampsia और severe preeclampsia जिसके वजह से fetal growth restriction हुआ है. दोनों के babies है 2 kgs के at 37 weeks, which I know is less than required. But एक में है SGA, एक में है fetal growth restriction. How do you differentiate between both of them? Both on the percentiles are on second percentile. I'm just telling you, for example, both are on second centile. So how do you differentiate?
Sir, a SGA baby is a constitutionally small baby. So in that the biometry, like the head circumference upon the abdominal circumference of the baby, or the femur length of the upon the abdominal length of the baby will be normal, whereas in FGR it will be increased. And the other indices like the abdominal growth rate and the ponderal index will be normal in an SGA baby but decreased in an FGR baby.
Sir, also the mother, she's constant, like she's small herself. So the genetic potential of the SGA baby is, like mid maternal and paternal height would be lesser. And but that is not the case for the tall and averagely built lady.
Okay, so simply put, the baby which is which is constitutionally small is at par with its genetic potential. Even when it is born, it is always going to be small with respect to its batchmates, its friends, its peers. It is always going to be a small person. The person is going to be a small-heighted, petite girl or a petite person. They are going to be small always. Whereas the babies with fetal growth restriction have not yet achieved their genetic potential because the placenta or whatever factor in utero was impeding its complete growth potential. But once it is delivered, बाहर आने के बाद में मैं उसको पूरा न्यूट्रिशन दूंगा, सपोर्टिव एनवायरनमेंट दूंगा, it will cover up for that. So 1 year down the line, probably the baby which had FGR is going to be let's say 6 kgs, but ये जो दूसरा वाला था वो 4.5 kg का ही रहेगा. But that wouldn't mean कि ये 6 kg वाला हेल्दी हो गया और ये 4.5 kg वाला अनहेल्दी रह गया. No, the genetic potential is the difference. And what is stopping the genetic potential from being reached in that baby with FGR are the risk factors and the causative agents for fetal growth restriction. ठीक है?
Yes, sir.
Okay. So now that I've mentioned about the causative factors or the risk factors, then could you just tell me what are the risk factors for fetal growth restriction?
So there are maternal, fetal, placental, and placental factors. So
Very good.
maternal factors include age over 40 years, low
Okay.
BMI.
Could you also explain me each and every factor because I wish this is a session that is very elaborate. So could you tell me the reason why age is a risk factor?
Sir, because there are more chances of chromosomal aneuploidies at a
Okay.
high
So the
age.
quality of egg is poor, which is why you're going to have possibility of fetal growth restriction, some genetic impairment or chromosomal abnormality. Okay. Anything else? You wouldn't say aneuploidy. Remember that aneuploidy, these babies are going to be aborted in the first trimester, mostly. So aneuploidy wouldn't be the answer for the age factor. You can instead say that because the age of the ovum is much high, it will have micro deletions, it will have small DNA defects or mutations, which will not let the baby grow to its own potential. So poor quality of egg is a better term because it is very obvious that in today's day and age, if you are saying aneuploidy as a risk factor for fetal growth restriction, these babies don't usually reach a third trimester. They are picked up early and aborted in most cases. So do not mention aneuploidy as the first factor. You can mention it down the line.
Okay,
ठीक
sir.
है. Next.
Sir, low maternal BMI, less than 20. Like the maternal nutrition will be poor, which would
Okay. Yes,
lead to
correct.
poor fetal nutrition.
Okay. And will also predispose a female to various infections. Which
Yes, sir.
infections in particular?
So like tuberculosis or like recurrent UTIs.
Okay. Talk about the commonest infection that is going to lead to fetal growth restriction. Intrauterine infection,
Yes,
low
sir. Torch
immunity,
infections.
torch infection, very common. Okay, continue. What other maternal factors? You mentioned age, poor nutrition status, which is less BMI.
Sir,
What else?
poor weight gain during pregnancy or malnutrition in general in the mother.
Okay, fine.
Then
Next.
hypoxemia or lung disease in the mother.
Very good. Hypoxemia, lung disease like COPD or maybe even asthma. Or if the person or if the female is staying in a higher altitude region, she's staying at a higher altitude. Why? Why
Sir,
should that lead to? मतलब ये देख, अगर तेरे पेशेंट को COPD है, even if you put your probe oximeter on her finger, it is going to show you an oxygenation of 98-99% because she is well compensated for. Then what is the reason that fetal growth restriction is occurring? Vijay
sir, ऐसा
Lakshmi, whoever it is, I think you would want to stop your camera. Your camera is on, Vijay Lakshmi. Okay. Yeah.
sir, if the female has hypoxemia, um,
Hmm.
there would be increased there would be increased RBCs of the compensatory mechanism, which could lead to
It could lead to
clot.
cascade of like thrombosis, stroke, polycythemia, stroke, or peripheral artery disease, or any other such diseases.
Very
which would
simply
also
put, the
lead.
viscosity is going to increase of your blood. If
Yes,
the viscosity increases, it will find it very difficult to go through the microcirculation of the placenta. Okay, so that is the reason. Very simple. Your hypoxemia, hypoxic blood diseases, or higher altitude increases the viscosity of your blood, and viscous blood finds it very difficult to go through those small arterioles, which leads to fetal growth restriction. That's it. Okay.
yes.
What else?
So
Maternal
smoking,
smoking. Very good.
alcohol,
Why
or drugs.
smoking?
So because it can cause vasoconstriction or endothelial dysfunction.
Because of the nitric oxide release.
Excellent. Very good. Nitric oxide. Oh, nitric oxide तो vasodilator है. वो तो अच्छी चीज है. Are you sure that you mentioned the right molecule?
Not nitric oxide.
Carbon monoxide and nicotine.
Because of the carbon monoxide. Sorry.
Yeah, carbon monoxide and nicotine.
Yeah,
They are going to be the vasoconstricting agents, and that is going to impair your placentation. Okay. What else?
So previous previous history of preeclampsia or small for gestational age baby or
Very good.
stillbirth.
Very good. So basically, the female has a genetic tendency to develop placental disease. Correct. What else?
So any maternal disease with like a vasculopathy, like preeclampsia, chronic hypertension, diabetes, chronic renal disease, or an
Excellent
autoimmune
answer.
disease like
Excellent answer.
Tilak.
Very good. So any
So,
vasculopathy, long-standing vasculopathy, including chronic diabetes, over diabetes mellitus, very good. Anything else?
sir, any autoimmune condition like Apla syndrome or any
Very good.
thrombophilia.
SLE, Apla syndrome, very good. So autoimmune destruction of the syncytial trophoblasts, basically the impairment of your trophoblastic invasion, very good. And lastly, substance abuse, just talking about all other substances as well, like even alcohol and things like cocaine and all those things which you don't usually find in our patients. Okay, so these are all your maternal factors. What about your fetal factors?
So genetic the problems like chromosomal abnormalities, aneuploidies, or microdeletions could cause symmetric FGR.
Yes, very good. Now that you have anyway mentioned, could you just tell me what symmetric and asymmetric is?
So
Symmetric, sir, based on the period, like when the FGR happens, whether it happens early in pregnancy or late in pregnancy, or generally in early pregnancy, it is symmetric AUGR and the sorry, it is it is symmetric FGR because the cause is a fetal cause. So the head circumference and the rest of the baby is uniformly decreased. But asymmetric FGR happens late in pregnancy, and there is a brain sparing effect. So the head is bigger, but the body is small.
Symmetric FGR is mostly because of the fetal intrinsic cause, and asymmetric is because of a maternal cause, mostly vasculopathy or other things.
Okay. Could you just mention the reason? I think I didn't hear you about why asymmetric IUGR or FGR develops?
Sir, in the early trimesters,
In the late trimesters, asymmetric IUGR develops.
Yes. Why? What is the pathophysiology?
So you said asymmetric, right?
Yeah, asymmetric.
Yeah. So in the asymmetric IUGR, it's asymmetric because the brain is spared. So because there is a uteroplacental insufficiency, the body has to prioritize where to send the blood. So it sends it to the important organs like the brain or the heart or the adrenal glands, whereas the liver and the kidneys have decreased supply. So the brain or the head is big and the liver and kidneys are small, like the rest of the body is smaller.
Very good. There is one important organ that is small that you didn't mention. It is not the kidney.
so
Kidney to
liver.
liver. Very good. Why the liver?
So because liver makes up most of the mass of the abdomen, and if the liver is small, the abdominal circumference would be small as well.
Okay. Anything else? Anything that reduces in the liver. You are
So
deprived of nutrition. Yes, very good.
glycogen.
Glycogen. You are deprived of nutrition, so the body has to pick up glucose from somewhere. So it utilizes all your glycogen storage from your liver. That leads to reduction in your abdominal circumference size because of the reduction in your because of the reduction. I think your screen has just gotten turned off. I think you'd have to share it again. Yeah. So because of that, it leads to your it just distracted me. So it leads to your abdomen circumference being small. Secondly, there are three organs that you mentioned. That's a very good point, and that's an excellent point, in fact, that you mentioned that there are three major organs that the body wants to make survive anyhow. Those are your brain, heart, and your adrenals. You would think why adrenals, but remember, you have read in your medicine that the most important life-saving hormone in your body is your mineralocorticoid followed, that is your aldosterone, followed by your glucocorticoids. So now what happens is the body recognizes that I am under stress and I may not be able to last till term, till 37 weeks. There might be a need that I have to be delivered before time in a premature state. And the body doesn't, the baby doesn't know that there is an option of me as an obstetrician giving the female betamethasone or dexamethasone from outside. So what the baby does is it says that let me produce my own corticosteroid through my adrenal glands, and that is why the adrenal gland is going to be the one that is salvaged so that it can produce glucocorticoids and can accelerate its own pulmonary maturation. So, if let us assume your patient, 35 weeks patient, is to be delivered immediately right now, and there is another patient who is in preterm labor but who doesn't have fetal growth restriction, and even that patient has to be delivered immediately, then the chances of surviving or the chances of having lesser complications are with the baby with FGR and not the baby with just prematurity, because the baby that was just premature, it did not get that stimulus of secreting its own glucocorticoids, whereas the baby with FGR had a stimulus that basically the blood was getting redistributed, and that led to it accelerating its own pulmonary maturation since a long time. And hence these babies are going to even be able to sustain through labor very well. They are going to be able to sustain periods of hypoxia during labor and as well as be safe after birth. Hence, FGR wale babies are said to be much stronger. But ठीक है, now that you have mentioned about symmetric and asymmetric, assume कर लो कि तुमने एक you have just delivered this baby at 35 weeks and उसी के बाजू में there was another female who was just in preterm labor for some reason and she delivered, एंड फीटल ग्रोथ रेस्ट्रिक्शन वाला बेबी का वजन आ गया 1.5 kg, दूसरे वाले का बेबी का वजन आ गया 2 kgs 35 वीक्स पे. What is going to be the difference in the physical appearance of both the babies?
Sir, so the physical appearance of an FGR baby is very typical. Like it has the absent buccal fat and loose peelable skin, and the abdomen is small. Like it has, and there's a large head with an open
Very good,
anterior
very good,
continent.
very good point that you mentioned about the skins. So when you were mentioning about the organs that are sacrificed, which included your kidneys and liver, there were two more organs that you didn't mention, and they were your skin, your subcutaneous tissue, and your intestines. Your skin and your subcutaneous tissue is also going to be sacrificed. Hence, your skin thickness also goes down, which is another reason why your abdominal circumference is lesser than your head circumference in a baby with FGR. Talking about the point on gut, that is your intestine. If anyone of you has done an NICU posting, or if anyone of you has been in a labor ward, and if you have seen a baby with absent end-diastolic flow or reversal of end-diastolic flow being delivered, you basically they're not fed anything through the mouth for the next 2 to 3 days after birth. The reason is that the complete blood supply to your gut, to your intestine, has been redirected to your brain, adrenals, and heart. So technically, your intestines are all ischemic. So if you feed these babies anything, the food is going to get, the milk is going to get accumulated in the intestines, and that can lead to necrotizing enterocolitis, necrotizing, and this can lead to even bowel perforation. So what we do is we wait for 2 to 3 days. हम लोग उनको intravenously glucose ये सब देते हैं, and we wait for the auto regulation to get restored and the baby's gut to get reperfused. And only after 2 to 3 days do we start them on oral feeds. So that is how you gradually shift a baby who was having fetal growth restriction or impaired blood supply inside the uterus to its own diet after birth. ठीक है? Again, coming back to your point, the differences, the physical differences.
Sir, there's also a large head with a wide, like an open anterior fontanelle. The
Yes.
abdomen is small and it is scaphoid. The umbilical cord is thin. There's poor breast bud formation. There's a loose fold of skin in the neck and the axilla and the groin. There's poor skeletal muscle mass and subcutaneous fat. The legs and the hands and limbs are small compared to the rest of the body.
Very good. Those classical prematurity complications of intracranial, intraventricular hemorrhage, necrotizing enterocolitis, respiratory distress syndrome, who are they going to be seen more in?
So they are going to be seen more in a preterm baby because the age is the term of gestation is less. But in fetal growth restriction, like you mentioned, there is corticosteroid.
Corticosteroid production, that is why. Yep, correct. ठीक है. So, definition of fetal growth restriction, fine. Um, you were talking about Doppler changes. Could you tell me ये जो तूने मेरे को definition बताया वो कौन से criteria में दिया गया है, which is the criteria used for defining FGR?
Sir, what we said was the FIGO 2021 criteria.
Yeah, that is correct. मैं तो GTG latest 2024 का बात कर रहा हूँ. एक ही criteria जो सबसे commonly use होता है, D से नाम है उसका.
Delphi criteria.
Is it the Delphi?
Yeah, Delphi criteria, very good. और Delphi consensus, dolphin नहीं है वो Delphi है जिसने भी ऑप्शन में बोला है आंसर में, it is not Dolphy, it is Delphi. Okay, so Delphi consensus या Delphi criteria है. I'll be just sharing the screen once to show the Delphi criteria. You don't change anything. I'll just share my screen now. So Delphi census या Delphi criteria, if I'm going to be talking about, in that scenario, this is the Delphi consensus that you can see on your screens right now. So in this Delphi consensus, now there was a close competitor that this consensus had, and that was your Barcelona classification. Barcelona classification में वो सब दिया था कि कितने वीक्स पे किसको डिलीवर करने का, एब्सेंट एंड डायस्टोलिक फ्लो को कब डिलीवर करने का, रिवर्सल को कब करने का. But this criteria is not mentioning anything about when to deliver. This is a criteria that is only given to define whether it is early or late FGR. So if I'm going to be talking about early and late FGR, as you can see, early FGR is the one जो 32 weeks के पहले ही शुरू होता है, and late FGR is the one जो 32 weeks के बाद शुरू होता है. So अभी obvious सी बात है, अगर 32 weeks के पहले start हो रहा है, so there is some problem with either the placenta or the baby in terms of, let's say, the placental formation was problematic or the fetus was having some problem. Before I move on to those fetal problems, could you tell me one point that was remaining was placental factors of the placental risk factors. Could you tell me what are the placental risk factors for FGR before I proceed on this?
Yes, sir. The placental risk factors are poor uterine flow because of maternal vascular, poor maternal vascular perfusion, or infarction, or abruption of placenta, or anti-apla syndrome, or velamentous cord insertion of the cord, or circumvallate or circummarginate placenta,
Or a single
Very good.
umbilical artery.
Single umbilical artery. Very good. Single umbilical artery is an indicator of some genetic defect that the baby has, जिसके वजह से single umbilical artery है. Single umbilical artery is not the problem. The problem is कोई तो genetic defect है जिसके वजह से उसको fetal growth restriction भी हो रहा है और single umbilical cord ही बना हुआ है. Now I have a very interesting and important question for you, a very deep concept. अभी तुम लोग हमेशा जो बोलते हो रिवर्सल ऑफ एंड डायस्टोलिक फ्लो या एब्सेंट ऑफ एंड डायस्टोलिक फ्लो, वो कौन से वेसल में बोलते हो?
Sir, umbilical artery.
Okay, umbilical artery, correct. Now I'll draw you a diagram and I'll ask you one question. I hope my diagram is visible. Okay, I'm now going to start drawing it. Just let me know if it is visible. तो ये था मेरा प्लासेंटा, रेड कलर से मैं जो बना रहा हूँ अभी. दिस वाज माय प्लासेंटा. इसमें से मेरा अम्बिलिकल कॉर्ड आया. ठीक है, ये अम्बिलिकल कॉर्ड में था दो आर्टरीज और एक वेन. I think there is someone whose speaker is on. Who is this? Shweta, organizers, please mute Shweta or maybe remove her from the room. Yeah. So, just a moment. Yeah. So, वन वेन इज विजिबल दैट इज कमिंग, अम्बिलिकल वेन ये जो है जो आ रहा है, और ये दो अम्बिलिकल आर्टरीज है नीचे. इट कम्स इनटू द फीटस, इज गोज अपवर्ड्स, ये ज्वाइन करता है एक और वेसल को जिसका नाम है आईवीसी. ये जहां पे ज्वाइन करता है देयर इज वन कनेक्शन दैट इज कॉल्ड एज योर ductus venosus. Am I audible?
Yes,
Fetal
sir.
vein.
Okay. Now I have reached my heart. मैं हार्ट को बस ऐसा एक नॉर्मल 4 चेंबर का हार्ट बनाने वाला हूँ. This is my right atrium and right ventricle, and this is my left atrium and left ventricle. So this blood is now going to come and is going to drain in this. कुछ blood नीचे जाएगा और ये यहाँ से जाके blood जाने वाला है मेरे आयोटा में. ये आयोटा नीचे जाएगा, उसके दो ब्रांचेस बनेंगे कॉमन इलियक्स, उसमें से जो इंटरनल इलियक है उसमें से दो ब्रांचेस निकलेंगे, एंड दोस टू ब्रांचेस आर गोइंग टू बी योर umbilical arteries. Now this umbilical vein is the one, ये umbilical vein जो यहाँ पे मैंने blue में लिखा है, is the one that is actually bringing all the oxygenated blood to the heart. But despite that, whenever we talk about uteroplacental insufficiency, we mention about the changes in the umbilical artery and not the umbilical vein. Umbilical artery though is literally the leftover blood, deoxygenated blood, जो प्लस जो बेबी से मदर की तरफ जा रहा है. Then why should it make a difference to me? Why are all the definitions based on umbilical artery and not on umbilical vein? This is my first question. And my second question is, umbilical vein is bringing oxygenated blood, whereas umbilical artery is bringing deoxygenated blood. Then why is it named vein and artery when it should be the other way around? Two questions. Uditi, Apoorva, can you answer?
Sir, so the answer to your second question is artery is anything that originates from the heart to a peripheral tissue, similar for
Very
pulmonary
good.
artery also. And vein is
Excellent.
something that brings blood to the heart.
Very good. So in the uterus, in a placenta wala uterus, baby wala uterus, the lungs are not functional in a fetus. The placenta is doing the work of oxygenation. So the oxygenated blood is being brought by something to the heart, और heart से जो दूर जा रहा है वो मेरा है artery, which is why arteries and veins do not convey the level of oxygenation. They only convey the direction of flow, which is towards the heart or away from the heart. So umbilical arteries take the blood away from the heart, whereas umbilical vein brings it towards the heart. इसलिए उनके नाम वैसे दिए गए हैं. That answers my second question. What about my first question? क्यों है, क्यों ये definition सब दिए गए हैं with respect to my umbilical artery and not my umbilical vein? This is also
Sir,
bringing into the question my that group पे मैंने जो question डाला था, या जो आज सुबह मैंने question डाला था कि क्यों delayed cord clamping किया जाता है. So yeah, tell me.
sir, most of the indices are defined based on arterial measurements like uterine artery, umbilical artery, or middle cerebral artery, because it has the like the muscular layer. It has three layers in the artery, while the vein is a single like it has only one covering with
And
walls.
so then based on the muscular layer, like the vasoconstriction or the vasodilation can tell if there is a more like decrease. If there's vasodilation, it can show brain sparing effect. If there's vasoconstriction, it can show pregnancy induced hypertension. So like because of that.
And the resistance index and the pulsatility can be calculated in artery more.
Okay, I agree with your point कि muscular है तो उसमें मैं indices calculate कर सकता हूँ, but you are forgetting a basic point. The more important vessel is my umbilical vein, because अगर umbilical vein में कोई कोची हुआ, the baby is not going to even receive blood. So why not say reversal or absence of flow in the umbilical vein? आर्टरी का क्या ही लेना देना है. आर्टरी इज लाइक कचरा है, बचा हुआ डीऑक्सीनेटेड ब्लड बाहर लेके जा रहा है. इट इज लाइक अ रिडंडेंट वेसल.
Sir, for the vein, the heart can pull blood, I mean, from the vein, and there is a
Then the heart can also push blood into the arteries. उसके पास तो मसल्स भी है पुश करके उसको आगे तक भेजने के लिए उसका पल्सेशंस.
sir, it is not a single column of blood. I mean, the ductus venosus is also there in between.
So I can even have a, I in fact do have a ductus venosus का waveform, And in fact, ductus venosus is the terminal event that we say. Ductus venosus में अगर reversal आ गया, it is the terminal event in which the baby is going to die.
Yes, sir.
तो वहां पे क्यों नहीं absent या reversal of end diastolic flow? वहां पे सिर्फ reversal ही क्यों?
Sir, because the heart will, I mean, the end diastolic flow would be something that comes after the heart, like the uh, uh, even in a
ठीक है.
like a
Let me tell you the
plethysmography.
answer. The answer is you were focusing on the vessels. The point of focus should have been this thing that you can see, your placenta. ना ये placenta जब भी उसमें ट्रोफोब्लास्टिक इन्वेजन में कोई भी प्रॉब्लम होता है, what does your trophoblastic invasion do? You had your trophoblastic cells and you had your spiral arterioles. What did they do? They attacked your spiral arterioles and they converted them to low resistance vessels. Correct? How
Yes,
did
sir.
they convert it to low resistance vessels? They destroyed 3 layers होते हैं मेरे पास, tunica adventitia, tunica media, tunica intima. उन्होंने ये 2 लेयर्स को डिस्ट्रॉय कर दिया पूरी तरह से. एडवेंटिशा जस्ट लाइक अ रैपर, सिर्फ बाहर का कवरिंग शील्ड जैसा रख दिया. 2 लेयर्स डिस्ट्रॉय कर दिया और उनकी जगह पे वो एक खुद का लेयर आके बैठ गए. सो व्हाट दिस डिड वाज, instead of 3 layers, now we have only 2 layers, the layer of trophoblasts and the layer of tunica adventitia. This increased the blood supply to the uterus and to the placenta. This eventually led to the placenta being a low pressure system. अभी ये जो लो प्रेशर था, दिस इज व्हाट हैपेंस नॉर्मली. बट एज्यूम कर लो ये ट्रोफोब्लास्टिक इन्वेजन हुआ ही नहीं और ये वेसल वैसे का वैसे ही रह गया. सो दिस लो प्रेशर वाज नॉट क्रिएटेड एंड इंस्टेड दिस प्लासेंटा बिकेम अ हाई प्रेशर वाला जोन. अभी ये जब हाई प्रेशर वाला जोन था, सो टू पास द ब्लड इनटू दीज वेसल्स, ये अम्बिलिकल आर्टरीज को ज्यादा काम करना पड़ा और हार्ट को भी इवेंचुअली ज्यादा ताकत लगाना पड़ा टू पंप द ब्लड बैक इनटू द प्लेसेंटा. दिस लेड टू द वर्ड कॉल्ड एज increased resistance to flow in umbilical arteries. This reflected as increasing umbilical artery PI. PI is a way of measuring the resistance. So the resistance was increasing. I still didn't do anything and the resistance kept on increasing. It increased till an extent when there was complete stasis. There was absolutely no forward flow. This was called as absent end diastolic flow. I still did nothing at all. और फिर अभी धीरे धीरे ब्लड उल्टा बहने लग गया. And this was called as reversal of end diastolic flow. समझे? Now ये जो ब्लड है वो बैक फ्लो होना शुरू हो गया और ये जो बैक फ्लो है it started reflecting on this vessel over here, which was your ductus venosus. And hence, once the entire heart has failed and the heart is just unable to pump the blood in a forward direction and there are only back pressure changes, it led to changes in the ductus venosus and hence the terminal event was reversal of A wave in ductus venosus. This is said to be the terminal event. Terminal event क्यों? Because now even the heart has completely failed and now the baby can only die if you don't deliver the baby immediately. In fact, even if you deliver the baby at this point, the baby may still die in the neonatal period because the heart has failed. The heart is now simply unable to pump the blood forward and वो literally एक failed heart जैसे जहां से भी blood का pressure आ रहा है वो ऐसे ही पीछे transmit करते जा रहा है. This is the reason why you measure the indices in your umbilical artery. Now the question that I had asked in the morning, the question being, why should I be doing delayed cord clamping? The question was, if I'm going to do delayed cord clamping, then I am clamping or rather I'm waiting for one vessel to be clamped late instead of these 2 vessels. So basically मेरा ये कहना था कि अगर मैं delay कर रहा हूँ cord clamping में, so the baby's heart is receiving blood through only one vessel, but the baby's heart is having an output through 2 vessels. So the baby is losing more blood than gaining blood. Then why should I be doing delayed cord clamping? And the answer, which was partly answered correctly by a lot of people, was the muscularity, the microanatomical structure. So if I'm going to look at the umbilical artery ka cross section, it is highly muscular. whereas the umbilical vein has very less of muscles. So इससे क्या होता है, once the baby is delivered, your intrauterine temperature was 37, 38 के बीच में. But when you are delivering the baby, either vaginally or in the labor OT, जहाँ पे भी कर रहे हो, the temperature is between 25 to 30. In fact, 25 degrees ही मान के चलो. So it is cooler outside than it is inside. इतना ठंडा है कि ये वेसल ने जल्दी कॉन्ट्रैक्ट कर गया. Which one? The umbilical artery. वेराज ये अम्बिलिकल वेन में वेसल्स के अंदर इतना था ही नहीं ट्यूनिका मीडिया कि वो ज्यादा कॉन्ट्रैक्ट कर सके, तो ये थोड़ा ही कॉन्ट्रैक्ट कर गया, विच इज वाई दिस वेसल वाज कंप्लीटली ऑब्लिटरेटेड, वेराज अम्बिलिकल वेन डिड नॉट ऑब्लिटरेट कंप्लीटली, इट वाज स्टिल प्रोवाइडिंग जो भी बचा कुचा ब्लड था टू द फीटस. नाउ दिस इज द सेम concept that we always use even in a patient with cord prolapse. They always say that whenever there is a cord prolapse, if your hand is already inside the vagina, do not bring it out, because if you bring it out, तुम्हारा जो ग्लव का टेम्परेचर है उसके ऊपर एमनियोटिक फ्लूइड है, ब्लड है, बिकॉज ऑफ द एसी इट विल बिकम ठंडा. एंड इफ यू री इंसर्ट इट इनसाइड, और इफ द कॉर्ड कम्स आउटसाइड द वजाइना, then because of the outside temperature the vessels will constrict and the baby will lose its blood supply. So what you have to do, if you have a cord in your hand, cord collapse हो गया, तो हाथ अंदर ही रखना है सिजेरियन सेक्शन होने तक, वजाना के अंदर ही रखना है, so that the temperature doesn't fall drastically. You try to avoid touching the cord, जिधर है उधर ही रखो, ज्यादा पकड़ो मत, क्योंकि ग्लव का टेम्परेचर फिर भी कम है. You take the patient immediately for cesarean section, deliver the baby, and then you remove the hand outside the vagina. That is the reason why we practice this maneuver of reducing the handling and avoiding the cord from coming outside the vagina. And the same reason is the one किसके वजह से contract होता है vessels. Secondly, जैसे ये धीरे धीरे हो रहा है, the uterus is also contracting and the placenta is getting expelled by itself. Because the placenta is expelling, धीरे धीरे उसके सब vessels कटते जा रहे हैं, जो भी spiral arterial के connections थे, they were all getting sheared off because the uterus is involuting and the placenta is separating. Hence, धीरे धीरे लो प्रेशर वाला प्लासेंटा हाई प्रेशर का जोन बनते जाता है, and the umbilical artery stops sending any blood to it. So apart from this temperature induced reason, ये एक और रीजन है, जब प्लासेंटा खुद से सेपरेट होता है, the umbilical artery is not able to pump anything inside it, whereas the umbilical vein is still, जितना भी बचा कुचा ब्लड है वो बेबी का हार्ट खुद से सक इन कर लेता है, पंप इन कर लेता है. This is why delayed cord clamping is very important. Did everyone understand this concept? I would want to know in the chat. And Uditi and Purva, did you understand this concept?
Yes, sir.
Samjha? Okay, great. Did everyone else understand this concept? This is a very intricate concept, sir. Second point, अरे sorry यार, ये मैं पूरा point वापस नहीं समझा सकता. I'll have to be teaching till 1. I have a double emerge tomorrow. No, it's okay. जिनको नहीं समझा वो अभी जाने दो. This is a concept that is not even that important. It's a very nice concept to know. But did everyone understand? ठीक है. So next slide. History of presenting illness. So you mentioned that there is no history of any pain in abdomen, bleeding PV, leaking PV. Exact LMP was known. Patient and husband. No use of OC pills. Conception was spontaneous and dating scan was done. Patient and husband have a normal build. Okay, next slide. ओके, पेन इन एब्डोमेन था उसको, एक्सेसिव वॉमिटिंग था. एनी कोरिलेशन बिटवीन एक्सेसिव वॉमिटिंग एंड एफजीआर?
Sir, because of excessive vomiting, she was unable to take fluids or any food also. So that, I mean, that caused decreased nutrition in her.
या, वेरी गुड, गुड आंसर. ठीक है. कुड यू टेल मी, ये एक्सेसिव वॉमिटिंग जो होता है वो कौन से मॉलिक्यूल की वजह से होता है?
Sir, it's like hyperemesis is due to HCG.
ओके, एंड बीटा एचसीजी एंड एनी अदर मॉलिक्यूल?
HPL.
HPL, yes, very good. What else? There is a newest molecule जो अभी डिस्कवर हुआ है, which is in fact one of your NEET का answers at some point.
Sorry, sir. No.
ठीक है, नो प्रॉब्लम. इट इज GDF15, ग्रोथ डिफरेंशिएटिंग फैक्टर 15. ठीक है. द रीजन आई आस्क्ड यू दिस क्वेश्चन वाज HCG. अगर उसको एक्सेसिव वॉमिटिंग है तो इसका ये मतलब हो सकता है, नॉट नेसेसरीली, हो सकता है दैट हर HCG levels are more than normal. Is an HCG level more than normal a risk factor for your fetal growth restriction?
Sir, if the HCG is extremely high, it could be molar pregnancy.
Okay, molar pregnancy. And if it is not extremely high, slightly high?
It could be like it normally is high in pregnancy.
अरे नहीं, मतलब नॉर्मल वाले वैल्यूज से थोड़ा ज्यादा, तो जितना प्रेगनेंसी का नॉर्मल वैल्यूज है उससे थोड़ा ज्यादा अगर है तो क्या, व्हाट इज द इम्प्लीकेशन?
Sir, molar, I mean,
नो, इट इज अ
molar.
नॉर्मल फीटस, डोंट थिंक अबाउट मोलार.
Hmm.
मोलार इज लाइक
Is
थाउजेंड्स
it
लैक्स में
a
गया.
twin
यहाँ पे थोड़ा सा
pregnancy?
ज्यादा है. ट्विन प्रेगनेंसी ठीक है, व्हाट इफ इट इज सिंगल? So excessive beta HCG is an indicator of possibility of some aneuploidy that is underlying. कोई तो एन्यूप्लॉइडी या जेनेटिक डिफेक्ट है जिसके वजह से द प्लासेंटा का कुछ तो प्रॉब्लम आ रहा है एंड सिंसिशो ट्रोफोब्लास्ट ज्यादा है एंड दे आर सिक्रेटिंग मोर ऑफ एचसीजी. So it might point towards some problem of the placenta. It can be an aneuploidy or the excessive sincere trophoblast, because of some reason they are over functioning. So I would want to do those dual markers and quadruple marker. अगर dual के तो quadruple का जरूरत नहीं है, to just know कि ये क्यों है, what is the risk, is it an aneuploidy that I'm looking at. So yes, beta HC ज्यादा होना is a risk factor for fetal growth restriction because it points towards the possibility of some aneuploidy possibly. ठीक है. So she had this till 7th month of gestation, and due to financial constraints, now that you have anyway mentioned about hyperemesis, could you just quickly, within a minute, tell me what is the treatment of hyperemesis quickly?
Sir, we give IV fluids to her along with an antiemetic.
Okay. Which antiemetic is the drug of choice?
Sir, doxylamine.
Doxylamine, very good. Doxylamine is the drug of choice. Good. Um, is there one particular vitamin that you would want to supplement?
So pyridoxine.
Okay. Apart from that, much more important. Starvation
Thiamine.
में patient. Thiamine,
Thiamine.
very good. Starvation में है patient. You wouldn't want to induce psychosis in that patient because of glycogen, yeah, glucose in your body being given without thiamine. The same thing that happens in patients with CLD, that you never give glucose without thiamine. Thiamine is something that you should be giving every morning before you transfuse them with glucose. And the first thing that you do for them is to keep them off diet for a while. For 2 to 3 days, you just keep them completely nil by mouth. You just give them intravenous fluids so that the nausea goes away. ठीक है. So she was unable. ठीक है. No history of fever with rashes, bleeding, PV, exposure to radiation. क्या significance है इस case में?
Sir, fever with rashes, if the mother had, it could indicate that she had a torch infection and
Okay, very good.
which could lead to FGR. Bleeding PV could signify, I mean, abortion or chronic abruption in the mother.
Okay, very good. Bleeding PV, exposure to radiation. ठीक है. Bleeding PV significance. That's a good point. First trimester में bleeding PV, that is threatened abortion. Why FGR?
So, if there is chronic abruption and there is a clot behind the placenta, then that area won't be able to perfuse the fetus till
Very good. Those
term.
clots are going to destroy the spiral arterioles वहाँ का जो भी local है. So वो permanently रहने वाला है वैसे का वैसे. वो फिर से regrow नहीं होगा. So clots and bleeding PV can indicate placenta is not attached properly. वहाँ पे bleeding अगर जमा हो गया है तो. ठीक है. Exposure to radiation. Why?
So increased exposure to radiation is teratogenic.
Okay. And drug intake. Which drug in particular
So ACE
can lead to?
inhibitors, ARBs.
Beta
Yes. What
blocker.
else? बीटा ब्लॉकर, वेरी इंपॉर्टेंट. वैसे भी हम लोग एस इनहिबिटर्स एआरबीस को प्रेगनेंसी में देते नहीं है, बट जो देते हैं वो है बीटा ब्लॉकर्स. Which patients would you find beta blockers being taken in?
Sir, hypertensive mothers, like with
Uh,
chronic hypertension
okay, what else?
or
Much more
heart
common than
disease.
that. हार्ट डिजीज वेरी कॉमन. उनमें हम लोग मेटाप्रोलोल देते ही है, कार्डियो स्पेसिफिक है, बट स्टिल इट हैज एन एक्शन ऑन द प्लासेंटा एंड इट कैन लीड टू फीटल ग्रोथ रेस्ट्रिक्शन. ओके, नेक्स्ट स्लाइड. So weight gain was 4 kgs till 6 months. Was it ideal?
No, sir.
लेस देन आइडियल. सो लेस देन आइडियल क्या इंडिकेट कर रहा है? माल न्यूट्रिशन.
Yes,
इफ
sir.
यू
And also
या
decreased
टेल
growth
मी.
of the.
Decreased growth of the fetus. If it would have been 10 kg, मान लो 6 month तक, would that have been abnormal? Would that be a risk factor for fetal growth restriction?
Yes, sir. Because it, I mean, it could, the extra weight could be because of edema in various parts, which
Very
happens
good.
in PIH.
Which happens in preeclampsia. Very good. So
Pre-eclampsia.
preeclampsia, edema, peripheral pedal edema, जिसकी वजह से weight gain ज्यादा हो सकता है. Okay. So the blood sugar, BP, everything, HB was normal. Iron, folic acid was given. Quickening was felt. She had fever in the 6th month for a day, which she visited a local clinic. Okay. You have mentioned that she had an episode of leaking PV. Do not mention leaking PV because अगर leaking PV है तो your viva might just go towards PPROM. Instead, even though she is giving you a history of that, you can rather say a patient mentioned of an episode of vaginal discharge because it has resolved and she doesn't have PPROM right now. So it has been resolved. So of course, वो leaking PV नहीं था, discharge PV था. And pessarian antibiotics are not given for leaking PV. They are given for vaginal discharge. So just ensure that. No history of headache, blurring vision, epigastric pain, decreased urine output. क्यों ये line दिया हुआ है?
Sir, to rule out preeclampsia.
The premonitory symptoms of preeclampsia.
Premonitory symptoms. Okay, fine. Good. Next. Okay, next. Okay, nothing significant over here. Next history. Okay. CKD, tuberculosis. Why you mentioned CKD and epilepsy?
Sir, the treatment for epilepsy could be teratogenic, phenytoin. Is-
And so
Yes,
CKD could be a maternal vasculopathy, which is a risk factor.
very good. Excellent answer. Vasculopathy plus hypoproteinemia का state है. Malnourishment होता है इनमें. That can be one of the causes. And also the drugs that they are taking, CKD के patients को काफी बार hypertension होता है. So they might be taking ACE inhibitors, ARBs, which may be unchecked, जो ले रहे होंगे. एपिलेप्सी एक और रीजन है. फेनेटोइन तो ठीक है, मतलब बहुत सारे लोग प्रेगनेंसी प्लानिंग के पहले चेंज करते हैं. बट वन मोर रीजन एपिलेप्सी या एंटी एपिलेप्टिक ड्रग्स की वजह से एफजीआर हो सकता है. व्हाट इज दैट?
Um,
Lithium,
No. Lithium as an anti-epileptic agent is anyway very rarely given. It's more of a mood stabilizer.
sodium valproic acid.
Yes, फेनेटोइन, सोडियम वैल्प्रोएट उसमें से एक कॉमन फैक्टर है जिसकी वजह से फीटल ग्रोथ रेस्ट्रिक्शन होता है. कौन से माइक्रो न्यूट्रिएंट का डेफिशिएंसी होता है उनसे?
It's cause of folate deficiency.
फोलेट डेफिशिएंसी से न्यूरल ट्यूब डिफेक्ट्स तो बहुत ही सिग्निफिकेंटली कम होगा. फोलेट तो होगा बट दैट कैन स्टिल लीड टू, इफ इवन इफ नॉट फॉर न्यूरल ट्यूब डिफेक्ट्स, दैट कैन स्टिल लीड टू low birth weight. So pre and conceptional folic acid is also going to help you prevent fetal growth restriction. Bleeding disorders, long-standing illnesses, no history of Apla syndrome. How does Apla syndrome lead to fetal growth restriction?
Sir, Apla syndrome can cause clot formation in the placental arteries, which can reduce the blood supply to the fetus.
Very good. So basically, they are going to destroy the endothelium of the spiral arterioles, and that will lead to coagulation cascade and multiple small blockages in your placenta, which is why it is also a criteria for preterm birth, preeclampsia, everything. Now, you have mentioned a very interesting point, which is something that I appreciate, that you have said that she had psychosocial stressors, including a substance abuse in the husband, even verbal abuse with the mother, and a history of disordered eating before marriage because of anorexia nervosa. Now, this is something that I tremendously appreciate. This is something जो मैं पीजीज के भी हिस्ट्री में नहीं मिलता है मुझे. लोग सब कुछ बात करते हैं लेकिन मेंटल स्ट्रेस का तो कोई बात ही नहीं करता है, विच इज इनफैक्ट वन ऑफ द मेजर फैक्टर्स कि आजकल के पेशेंट्स को प्री सब होता है. So that's a very good point and I appreciate this. And I would definitely recommend that अगर ये तुम लोग एग्जाम में भी बताओगे, that is going to fetch you those brownie points. एक दो लाइन तो बतानी ही है. वेरी वेल नोटेड. इनफैक्ट नो वन इज इवन एबल टू एलिसिट दिस हिस्ट्री. बहुत सारे फॉर्मेट्स में भी दिया नहीं रहता है. कोई जो प्रोफॉर्मर्स दिए शर्मिला बाबू ये सब में दिया नहीं रहता. सो दिस इज अ वेरी गुड पॉइंट दैट यू हैव नोटेड. कुड यू जस्ट ब्रीफली टेल मी कि स्ट्रेसर से क्यों होगा एफजीआर?
Sir, anorexia nervosa is a state where the mother will eat less and is malnourished. So that could lead to FGR.
यस.
Stress, stress in itself could cause increased cortisol, which would cause an increased cortisol level in the fetus also,
ओके.
um, which would retard the fetal pituitary's action. Like HPA axis would be suppressed, and which could cause fetal growth restriction.
ओके, गुड इनफ.
On
आई
a
वुड गिव दैट टू
parallel
यू.
note, like there's a non-supportive home environment, so she's not able to get the support to take care of herself during the pregnancy.
वेरी गुड. ऑल्सो डिस्टर्ब स्लीप बिकॉज ऑफ दिस इज गोइंग टू. जब भी तुम लोग सोते हो तभी देयर इज अ सिंपैथोलाइसिस, सिंपैथिक ड्राइव कट जाता है. बट इफ यू आर नॉट गेटिंग एडिक्वेट रेस्ट, then there is going to be sympathetic overdrive. That is, in fact, a predisposing factor to heart disease and preeclampsia or even chronic hypertension, which is going to predispose to fetal growth restriction. So even that part. So yes, very good history. I would definitely appreciate this if everyone is going to ask those patients. Okay, next. Sleep decreased, very good. I hadn't seen this. So yes, good. Sleep decreased, definitely a significant point. We just spoke about it. Bowel, hard stools. Hard stools, कुछ correlation fetal growth restriction के साथ?
So it's sometimes common during pregnancy, so we do not really.
Yeah, it is common in pregnancy, but one more thing is poor roughage fibrous fibers in the diet has been reduced. So micronutrients जो आते हैं fruits and vegetables से तो वो भी कम है. A few people say hard stools होते हैं even because of आयन आयन के कंजम्पशन से. सो ठीक है, दैट इज वन पॉइंट. ठीक है, ब्लैडर इज नॉर्मल, डिनाइज एनी एडिक्शन, एंड द ब्लड ग्रुप इज ए पॉजिटिव. ब्लड ग्रुप का कोई सिग्निफिकेंस?
So to rule out RH negative pregnancy and if that causes any complications in the fetus.
ठीक है, चलेगा. आइसो इम्यूनाइजेशन. ओके, नेक्स्ट. डाइटरी हिस्ट्री ठीक है यार, प्लीज. ये तो पीएसएम की बात आ गई. नेक्स्ट स्लाइड. बराबर लिया है तूने, डेफिसिट है, सब कुछ एक्सेलेंट बोला है. बट देन मेरे से अभी ये उम्र में नहीं होता है वो सब. फैमिली हिस्ट्री ठीक है. Why stress can cause FGR, Kshitij? Uditi, could you just quickly, there's a doubt in the chat section. Could you please quickly tell me why does stress cause FGR?
So stress increases the cortisol production in the mother, which increases the exogenous cortisol in the fetus, which could suppress the hypothalamic, like the HPA axis, which could lead to the FGR.
Okay, correct. And HP axis भी derange हो रहा है. That's it. ठीक है. Family history. The mother had 6 children. Mother as in her mother. Okay, so her mother herself had 6 children. Socio-economic lower background. So she has been malnourished since her own childhood. ठीक है. Husband consumes chewing tobacco. Very very good point. मस्त point बोला. ये भी मेरे को मिलता नहीं है किसी की history में. Is that and will that lead to FGR?
Yes, sir. If the husband consumes tobacco in any form, that could cause defective sperm production, which could cause defects in the fetus itself, firstly, and
Genetic.
also, genetic like microdeletion or methylation problems in the fetus
Very
itself.
good. DNA
And
fragmentation, microdeletion. Very good.
yes, sir. Also, it could cause placental abnormalities because the placenta is made more from the paternal component.
Amazing answer, beautiful answer. Placenta has significant number of a significant percentage of paternal antigens. So paternal antigens play a big role in how the placenta is made, and hence defective placentation is going to be because of paternal factors, which no one asks for. Excellent answer. Lovely. Okay. No history of diabetes, autoimmunity, thyroid disorders, no history of congenital disorders. So, okay, no history of any congenital disorders or no history of congenital. Fine. Okay, next slide. By the way, for everyone, there's a feedback form. that we have posted in the comments. Kindly, it's a request that everyone fills it, and that would help us with the attendance as well as to provide certificates. This is a very nice session. I'll be posting it in the chat again, and I'll be pinning it. Kindly fill the form. Okay. So general examination, thin build, poorly nourished, height is very poor, pre-pregnancy BMI is 16.4, which is very undernourished. Current weight is 50 kgs, inadequate. No abnormal gait or spinal deformities, fine. Next, Bhavesh, please mute. Next, next slide. Temperature afebrile, pulse 82 per minute, regularly, okay, pulse nothing, respiratory rate 20 per minute, abdominothoracic, blood pressure 110/80, upper limb. In sitting position, no pallor, icterus, clubbing, lymphadenopathy, edema. Okay, next. CVS is normal, everything is normal. Breast examination is normal. Okay, next. Obstetric examination. Okay, come to the palpation. Fine. Could you tell me the difference between fundal height and symphysiofundal height?
So fundal height is what we measure by palpating with our palm and estimating based on that. And symphysiofundal height is what we measure with a tape
from the pubic symphysis to the top of the fundus, to the top.
Okay. Okay. Could you just tell me the exact technique to measure the symphysiofundal height with the tape?
So the legs are extended, then the fundus is felt uh, as we do for fundal height. Then the pubic symphysis is felt, and from the top of the pubic symphysis to where our hand is, we measure the length.
Okay. There is one fine point. Which side of the tape do you place on the abdomen?
So centimeter.
Okay. Which side is facing you?
So we did not understand the question.
Okay. So basically, a tape has two sides, an inside and a centimeter side. So you will always place the inch side facing you on the abdomen because there is a tendency to try to average out or to try to get जितना gestation age है उतना ही हम लाने की कोशिश करेंगे हम खुद से voluntarily involuntarily subconsciously हम try करेंगे adjust करने का so to avoid this bias what we do is we do not keep the centimeter side facing us we keep the inch side facing us we mark the point जहाँ पे वो fundal height मिल रहा है and then we overturn the tape and then we see कि कितना centimeter है this removes the bias of us adjusting subconsciously for the gestational age ठीक है so inch का side ऊपर हमेशा होना चाहिए. So whenever you're asked to demonstrate in the exam, two important points. एक है, this is one of those rare tests that are done with the extended hip joint, and secondly, keep the tape with the inch side facing you and the centimeter side lying closed or lying hidden on the abdominal wall. ठीक है. So in your case, there was a lag of what 3 weeks. Would you say that this is what from what severity of FGR?
Sir, mild.
Okay, mild FGR है good. What is severe FGR?
Sir, severe FGR is uh, where the
Lag is more than 4 weeks.
The lag is more than 6, 4 दोनों बोलते हैं लोग. मैं खुद 6 मानता हूँ. मैं तो FGR भी 4 से ज्यादा है तो ही मानता हूँ. But severe is definitely more than 6.
Okay.
Someone has asked in the comments, Uditi, I would want you to answer that. Why not in the flexed abdomen? Symphysiofundal height.
Sir, in a flexed abdomen, we want to be like the uterus would firstly be pushed up, and the like it will be difficult to palpate the pubic symphysis also.
Very good. Excellent. Precisely. ठीक है. Okay, so abdominal girth भी वैसे था. Could you tell me if you could calculate the fetal weight from these findings that you have given?
So there's called the Johnson's formula in which
Which
we
formula? Your voice wasn't clear. Which formula?
the Johnson's formula.
Okay, what's the Johnson's formula?
in which the formula is symphysofungal height minus 11 or 12. 11 is if the fetus is not below the ischial spine, and 12 if it's above. And then you like symphysofungal height minus this number into 155.
Okay, very good. So it gives you an approximate it gives you an approximate effective fetal weight, and then you bring out those charts which you will find on Google, और उसके ऊपर तुम लोग देखोगे कितने percentile में है. For you to call a baby ideal for gestational age, what should be the percentile range?
So between 10 to 90.
Yes, correct. 10 to 90. 90 के ऊपर it is macrosomic. 10 के नीचे it is small for gestational age. And small for gestational age में you have your constitutional and fetal growth restriction that we have already discussed. ठीक है. So now coming to the end of the session, just nearing the end, not yet the end though. Tell me what are the major सबसे बड़े तीन या चार causes of FGR. एक था अपना प्लासेंटा का जो अपने केस में है, दूसरा था इन्फेक्शंस, तीसरा था क्रोमोसोमल एन्यूप्लॉइडीज. ठीक है, ये तीनों में व्हाट विल बी द मेजर डिफरेंसेस?
Sir,
हाउ वुड यू डिफरेंशिएट?
In like the
Sir,
mother
no, in
or in the fetus.
the chromosomal aneuploidy would be a symmetrical FGR. The
ओके,
placental
एंड व्हाट
would
टेस्ट
be
वुड बी नेगेटिव? इसमें नेगेटिव क्या होंगे और पॉजिटिव क्या होंगे? यू हैव टू टेस्ट, एक है डॉपलर, एक है ब्लड टेस्ट. तो सब में मुझे बताओ किसमें क्या एबनॉर्मल होगा?
certain chromosomal aneuploidies. The first trimester screening, the dual markers would be abnormal. Like that is the blood test. If we do the pre-fetal DNA, that would be abnormal. There would be no placental changes as such. In infections, the blood culture would pick up infections,
ब्लड
but
कल्चर?
uh,
So even the clinical history, like the
WBC,
fever
yeah.
exanthem and WBCs will
Do
be
you know
raised.
that this classical history is found in less than 10% of the women? In most of them, they have a routine episode of coryza or what do I say, rhinitis, बस nothing else. एक छोटा सा एक दो दिन का फ्लू आके गया जो मुझे तुम लोग को भी आता है. So you would in most cases never be able to tell कि इसको torch infection होके गया है. So what are the other signs that you will get? Probably that will make you into thinking कि यार ये शायद torch
So
लग रहा है.
if there is a recurrent abortion, maybe in like if there was an abortion in the past.
No.
Absolutely wrong. This is a gross answer. After an impressive viva, I do not expect you to make this mistake. This is something we discussed in the last session.
Yes,
Recurrent pregnancy loss will never be caused by torch infections because you become immune to it. How would you diagnose torch or suspect torch?
so we could do the profile, like the PCR profile for torch infections.
PCR किसका? मदर का कि fetus का?
Amniotic fluid.
So amniotic fluids से there is a 0.1 chance of miscarriage. तो सब में तुम लोग PCR करोगे?
No, sir.
So वही what would make you into suspecting कि FGR है? हर FGR में करोगे amniocentesis?
Not in every FGR.
So how? What is the point that makes you suspect?
So the history maybe for torch, like it has a specific history for each condition.
No, it doesn't have. वही तो मैं बता रहा हूँ. सब लोग most patient बोलेंगे मुझे पता भी नहीं क्या था. शायद एक दो सर्दी हुई थी, हाँ हुई थी. नहीं हुई थी, नहीं हुई थी. It is very unspecific. Your answer to this is you are going to have an abnormal ultrasound, second trimester ultrasound. Second trimester
Yes.
ultrasound पे you will find changes in your CNS like ventriculomegaly या फिर intracranial calcifications, or you might have a small head that is microcephaly, or you can have polyhydramnios because of the hydrops that is occurring. You will have hepatosplenomegaly, you will have cataract. All these things are visible inside the uterus, and placentomegaly hoga in most patients. So all these signs on your hepatic calcifications milenge, all these signs on ultrasound are very difficult to miss. You will spot them in the second trimester itself. This will make you, or this will prompt you into doing amniotic fluid का PCR to confirm it. Hence, टॉर्च का जो मदर का टेस्ट है IgM IgG वो सबका नहीं करना है. ओनली इफ यू फाइंड अल्ट्रासाउंड पे ये सब फीचर्स तो जाके तुम करोगे. ठीक है? So your ultrasound is going to be abnormal in these patients. ठीक है. Congenital anomaly, same thing. You're going to have an abnormal ultrasound. The Doppler is going to be normal in most cases, except your fetal growth restriction because of uteroplacental insufficiency. Could you tell me what is the word or what is the terminology for fetal growth restriction in a monochorionic pregnancy, twin pregnancy?
Is
Sir,
it growth
A,
discordance?
growth discordance, yes, one of them. What else? Remember, growth discordance
Selective
में
fetal growth?
डॉपलर नॉर्मल होता है. इंपॉर्टेंट थिंग, ग्रोथ डिस्कॉर्डेंस में जस्ट एक बेबी छोटा है क्योंकि उसका जेनेटिक पोटेंशियल कम है या प्लासेंटा का कम पार्ट उसको मिल रहा है, दूसरा बेबी नॉर्मल है, बट दोनों का डॉपलर नॉर्मल होता है. What if the Doppler is abnormal for one of the fetuses?
Selective fetal growth.
Selective growth restriction, SGR, छोटा s, capital GR. Selective growth restriction is the terminology that you give for single fetus with Doppler changes in a monochorionic gestation. ठीक है? So how would you manage your patient?
Sir, firstly, we would give her nutritional supplements like amino acids
Arginine. And
Okay,
to
okay,
improve the nutritional status. We would ask her to rest in a like increase her sleep, improve the sleep that she has.
okay.
Start her like on a proper maternal nutritional diet, like with increased protein. Then tell her to monitor her fetal kick out. Then
Okay.
do her serial Dopplers
Yeah, serial ultrasound and Doppler
Yes,
every
very
week.
good. How frequently?
Every
every
week.
1 to 2 weeks.
Every 1 to 2 weeks. Okay. Uh, your answer is a little non-specific. Every 1 to 2 weeks, सब patients के लिए करोगे? कि it will depend on what your current ultrasound finding is.
Sir, based on current ultrasound findings, uh,
Okay.
if we
Okay.
have if we find an abnormality, then we will do it every week.
Okay. What abnormality?
Um, Sir, umbilical artery, like Doppler study, if it is abnormal, then
What abnormal? What is the abnormality that I'm looking at?
The
Be
systolic
specific.
diastolic ratio.
pulsatility index and resistance.
Yes. What about it?
If it is more than 90th% two
95th.
standard,
Okay.
yes, sir.
95th. Yes. So basically, if your umbilical PI is raised, umbilical artery PI is raised, which indicates increased resistance to blood flow. In that case, कितना frequently करोगे?
Sir, every weekly.
Okay, every weekly. 2 weekly is also okay. Weekly is also fine. तेरे condition में weekly is a better option क्योंकि 35 weeks already हो चुकी है. If there is absent end diastolic flow, तो क्या करेगी तेरे patient में?
Sir, every day we would monitor.
पक्का?
No, sir, we would deliver because she's already
Exactly.
35
Deliver
weeks.
करेगी. What is the upper limit for delivering absent
37.
end diastolic?
No, absent and diastolic flow we deliver by 31st, 32nd week.
क्या 32nd week? Are you sure?
37. 37.
37?
No, 34.
हाँ बराबर है, ऑप्शंस ने बराबर बताया है. सो एब्सेंट एंड डायस्टोलिक फ्लो में इट इज 32 to 34. एंड व्हाट अबाउट रिवर्सल?
So immediately we like
If there is
Immediately?
reversal in the
In your case,
ductus
yes, but
venosus,
what is the limit, gestation age limit?
sir, 28 to 32.
28 to 30. 30 weeks is
Hmm.
मैक्सिमम जिसके आगे मैं पुल करूंगा. अगर रिवर्सल है तो डीवी में
Then immediately.
then immediately. ठीक है. What if your fetal weight is less than third centile but every other Doppler parameter is normal? कभी डिलीवर करोगे?
Sir, 37th week.
Very good. 37. What if it is between third and 10th centile
Um, without any Doppler changes, sir.
without any Doppler changes?
So we could take it to full term, maybe.
Yes, that's a good answer, and that is what is accepted in most exams. But the recent most GTG says, मैं ग्रुप पे भी डालता हूँ उसका फोटो, कि 39 वीक्स पे प्रेफरेबली ये डिलीवर करो. जो 10 से नीचे हो गए हैं ना, 39 पे कर दो. बट 40 वीक्स तक भी करोगे तो इट इज फाइन. बट गाइडलाइंस बहुत सारे अभी कहने लगे हैं 39 इज अ बेटर ऑप्शन. ठीक है, तो 39-40 बोथ आर एक्सेप्टेबल. ओके, इन योर केस स्टेरॉइड दोगे?
So not necessary.
हेलो, क्या?
No, sir.
Not
She is
necessary.
35 weeks already.
अरे दोगे. द रिसेंट मोस्ट गाइडलाइन है कि 37 तक देना है हर एक पेशेंट को, इररेस्पेक्टिव कुछ भी हो, 37 तक तो देना ही है. मैंने लास्ट वीक ग्रुप पे ये भी डाले हुए हैं द स्क्रीनशॉट, द गाइडलाइन 37 तक देना है. ऑल द न्यू गाइडलाइंस से दैट. आई हैव अ
Okay.
क्वेश्चन फॉर यू. व्हाट और विच बेबी हैज अ बेटर चांस ऑफ सर्वाइविंग, अर्ली एफजीआर वाला या लेट एफजीआर वाला?
Sir, late FGR,
FGR.
asymmetrical FGR.
Okay, I'll reframe my question. Which baby has a higher chance of having sudden IUFD? Early FGR or late FGR?
Oh, sudden IFD would be more with late FGR.
Why?
Because if there is like sudden cutoff of the blood supply to the fetus, then it could cause death.
Very good. So to frame it a little better, early FGR में there is a placental problem जो मुझे पता है. So the baby is already gearing itself up since the first second trimester itself, second trimester rather, कि उसको कभी ना कभी तो जरूरत पड़ने वाला है जल्दी डिलीवरी का. So the baby has somehow managed to make itself adequate enough to survive डिलीवरी का और डिलीवरी के बाद का स्ट्रेस. बट लेट एफजीआर में द बेबी वाज हैविंग अ कोजी लाइफ, बट 32 वीक्स के बाद सडनली इट इज टोल्ड कि तेरे को आज से खाना नहीं मिलेगा, यू विल नॉट रिसीव ब्लड सप्लाई. And now the baby doesn't know what to do. The baby has been grown in an environment which is very conducive to a cozy life, a relaxed life. Which is why if the oxygen levels drop after 32 weeks, the baby is not accustomed to this, and there will be sudden, immediate brainstem ischemia. And वो brainstem ischemia की वजह से ये babies का IUFD होना ज्यादा likely है in comparison to early FGR. ठीक है?
Yes, sir.
Okay. So in your case, you will do an ultrasound and you would be proceeding, and depending on what your ultrasound says, you would determine when to deliver, whether to deliver her immediately or not to deliver her immediately. What would be your mode of delivery? अगर absent आता है तो?
Sir, what is absent? Like any
Absent
changes?
endostolic flow.
Oh, okay. We would try, like we would induce her for vaginal delivery.
For absent and for reversal, you will not attempt a vaginal delivery. The reason is there is no flow at all. So whenever there are uterine contractions, उसका जो थोड़ा बहुत भी blood है वो भी बंद हो जाएगा. So you cannot, the baby cannot sustain a vaginal trial. So for absent and reversal, it is cesarean section. For anything less than that, that is reduced flow, brain sparing effect, या just fetal weight being less, in that scenario, you would be able to deliver by vaginal delivery with proper CTG monitoring. Coming to monitoring, तुमने स्कैन किया, उस पे आया कि कोई डॉपलर चेंज नहीं है. Is there any other test that you would want to do to reassure yourself and the patient that the baby is doing okay?
Sir, biophysical score.
Okay, biophysical score, biophysical profile भी बोल सकते हैं. Biophysical profile के क्या क्या components है?
Sir, there are 5 components: fetal body movement, fetal breathing, fetal tone, the single deepest vertical pocket of the amniotic fluid in volume, and the non-stress test.
Okay, very good. कितना normal है score?
Sir, 10. Like if it's a full score, is like 2, 2, 2, 2 to each. 8 and above.
बराबर, तो 10/10 is normal. Okay. You mentioned about NST. कौन से वीक के बाद से हम NST कर सकते हैं?
Sir, 28th week, I think.
Would you want to try again? Could you tell me what is the basis of doing an NST?
Sir, to see the cardiac activity and the autonomic control, which comes.
Very good, very good. You mentioned a very important point, autonomic control, yeah, autonomic nervous system. So your autonomic nervous system is fully developed only by 34 weeks. कम से कम 32 weeks, not less than that. So below 32 weeks, you have a chance of getting falsely non-reactive NST. बीट टू बीट वेरिएबिलिटी नहीं आएगा, एक्सेलरेशन नहीं आएगा, एंड अननेसेसरीली तुम लोग उसको टर्मिनेट कर बैठोगे. इसलिए it is always advised that after 32 or even better after 34 weeks, you start doing NST. Yeah, you include NST in your BPP only after that gestation, because your autonomic nervous system is completely developed only by 32 to 34 weeks, after which it can respond to any amount of stress या hypoxia, and you would be able to notice it on your NST. ठीक है. Um, any other test that what is the other name for BPP?
Sir, don't know.
Okay, Manning score is the other name for it. What is modified BPP?
It includes the NST and the AFI.
Very good, NST and AFI. So it is a much more quicker thing to do, and it doesn't require too much of time. Ultrasound पे waste करने की जरूरत नहीं पड़ती है. ठीक है. ठीक है, then that is it about the session. And let me answer all the doubts. Before that, everyone, बहुत सारे doubts आए हैं. Before that, everyone kindly fill the feedback form. Uditi and Apoorva, I'll ask you a few of those doubts that have been asked in the comments. By then, everyone else kindly fill the feedback form and let me know also in the comments if you all enjoyed or if you like this session. And if you all have any other doubts, do ask them. So the first question is by Anish. If we can detect FGR early, why is there no definitive pharmacological treatment that reverses placental insufficiency? Are we approaching it wrongly by focusing only on the blood flow? Um, that's a very good question, Anish. Would you want to attempt this, Uditi and Apoorva? अपना अप्रोच गलत है क्या इन फीटल ग्रोथ रेस्ट्रिक्शन बिकॉज ऑफ यूट्रोप्लासेंटल इंसफिशिएंसी? हम लोग सिर्फ ब्लड फ्लो पे फोकस कर रहे हैं. कैन वी डू समथिंग डिफरेंटली?
So usually vasodilators are given, like
Yes, vasodilators, one of them being एक कोई drug, if you can tell.
phosphodiesterase 5.
Sildenafil, that's a good
हाँ.
answer. Sildenafil कुछ लोग दे रहे हैं. So what we can do is sildenafil हम देके in low doses we can artificially dilate the vessels. But the problem is trophoblastic invasion नहीं हो पा रहा है. So you will need some immunomodulator to ensure that the trophoblastic invasion is done properly. So if we can start looking at the immunomodulator side of things, if someone develops a drug that will enhance the trophoblastic invasion, then probably we can look after making a change in the outcome. Otherwise, बहुत difficult है. According to clinical experience, what is the most reliable way to differentiate between a constitutionally small fetus and a true fetal growth restriction when the Doppler studies are borderline? See, if the Doppler studies are, there is nothing by the way called as borderline. It is abnormal or normal. But अगर abnormal है, then it is not going to be a constitutionally small fetus. It is going to be fetal growth restriction as well. And the most reliable way is going to be, अगर मुझे एक fetal growth restriction और constitutionally small में देखना है तो मैं मदर को देखूंगा, उसका बॉडी का हैबिटस कैसे देखूंगा, वो खुद छोटी है क्या, वो सब देखूंगा. सबसे इंपॉर्टेंट मैटरनल हाइट एंड मैटरनल वेट बहुत सिग्निफिकेंट है, which will tell me whether the constitutionally small है या fetal growth restriction है. Plus after the delivery of the baby, I'll be able to look at the baby and be able to tell किसमें growth restriction था और किसमें सिर्फ constitutionally small था. If growth restriction is detected after 36 weeks and the fetal weight is less than 2, but CTG is reactive, would you plan immediate delivery or would you wait? That's a question for you, Uditi and Apoorva. If the growth restriction is detected after 36 weeks and the fetal weight is less than 2 kg, but the CTG is reactive, what would you do?
Sir, we can like take it till 37 and then deliver. Like,
How
and
would you determine कि 7 दिन खींचना है या नहीं खींचना है?
Based on
we do the Doppler.
Doppler, very good. So ultrasound is going to be the determining factor कि उसको खींचना है कि नहीं खींचना है. Okay. Next question is. Okay. Uditi, you had mentioned about the ferroportin and IUGR and iron. Could you just repeat it once? Someone has asked about it.
Sir, so when there is maternal anemia, there is a ferroportin-like thing in the placenta which shunts all of the, like selectively takes all of the iron from the maternal side to the fetus and helps in development of the fetus.
Okay, very good. So that is it about all the questions. So Uditi and Apoorva, you all knew a lot of intricate concepts, a lot of deep concepts, I would say, very well, very impressive. Though I would suggest that you read a little bit more of the basics as well, like basics like all those antenatal monitoring wala things. But otherwise, this has been an impressive Viva. Even the history was excellent. So well done, pretty well done, and all the best for your exams. So I hope we can get done with this session and everyone was benefited from this. So thank you so much, Uditi, and thank you so much, Apoorva, for today's session. It was great having you both on for this presentation. It was a great topic, and you would did definite justice to it. I was a little क्या बोलते हैं, I was a little क्या बोलूं pessimistic कि करेंगे कि नहीं कोई भी क्योंकि this is a very PG kind of a topic. But you did really well, and I'm very impressed. I believe it was at par with what a resident would present in their exams. So well done.
Thank you, sir, for this opportunity.
Thank you, sir.
Yes. So everyone, thank you so much. And with this, we log off. And the next session is not going to be on Monday. I have my double call and OPD after that. And we'll have the next session on next Saturday. So until then, I'll meet you again. And thank you so much. Good night. And please fill
So
the
much.
feedback form.
Please fill the feedback form before leaving the meeting because it won't be shared later on in the group or other forms. Thank you so much. I'll keep the meeting on for 3 more minutes for so that you have access to the feedback form link. I'll also reshare it now. उल्टी करते हैं बघून काय करू उलटी थोडी बंद होणार आहे बघून तो ते लादीवर करतोय